Good afternoon and welcome to Facebook Live. This is Bill Bird, Chief Medical Officer at CGH Medical Center in Sterling, Illinois. Thank you for taking the time to tune in. Today, looking forward to a conversation I'm going to have with a couple of our physicians who have begun a clinic for menopause and women's sexual health. So that's going to be the topic of our conversation today. And as always, as you watch this, if you go, hey, I think so-and-so would like to see this, and obviously, please feel free to pass it around. But I tell you what, without further ado, I'm going to stop just talking myself and get our two panelists on. So we have Dr. Marcia Jones and Dr. Nancy Tran. Marcia, Nancy, welcome.
Hi, thank you.
Hi, thank you. Thanks for having us on the program.
Yeah. Looking forward to hearing what you have to say about this. I know this is the latest and greatest clinic that we've begun to offer here at CGH. So I'm going to start it just with a simple question, and that is for each of you, if you would just kind of say, how did you become interested in menopause and women's sexual health?
Okay, do you want me to start?
Yes.
Okay, so I've been doing hospital medicine actually for the last 22 years. So I care for acute, sick inpatients in the hospital. So my focus there has been figuring out why they're sick, why they're requiring hospitalization, how to get them better, and really setting up follow ups with their primary care doctors and maybe some of their other specialists. So why this new path? So I would say a few years ago, I heard a lot about testosterone for women. So mostly pellets, but then I thought, is this voodoo medicine? Like, I didn't know much about it. I never learned much about it in medical school or nothing in residency training in internal medicine. So then I started doing more research about it. I attended a conference last year on testosterone, and I met a female urologist, Dr. Rachel Rubin, there, who was giving a lecture for testosterone for female sexual health. And I learned that a large part of female sexual dysfunction occurs during like perimenopause and postmenopause. And that kind of naturally led me to this new passion in menopausal care for women. I also do admit that some of this is very personal. I was transitioning myself during the menopause transition. I felt like very frustrated that I didn't know much about it. Like, why am I a doctor? I'm an internist, and I didn't know what all the symptoms are and how to treat it. So, um, I was like, well, how come I didn't learn it? Did what I learned, was it outdated? And I really wanted a menopause expert to consult on. So I looked to the Menopause Society for guidance, and then I became one of their board certified practitioners. So right now, I still practice hospital medicine on my 1 week a month, and then on my weeks off, I work in the menopause clinic.
Yeah. Very good. And, and I forgot to mention this when we started, but Nancy, you alluded to that both you and Marcia are Menopause Society certified practitioners. So you've done some training beyond medical school residency, and now you have some special expertise in the ability to take care of women who are in that process of going through menopause. Marcia, how about you? What's your story in terms of what got you interested in this?
Sure. I've been in primary care, doing family practice here since 2001. And initially in my practice, I did some menopause care for women, but our world turned upside down in 2002, and we'll talk more about that later. And so over the last 20 years, I see a lot of women listen to their stories. They have a lot of symptoms, and the knowledge base seems to be lacking on my part because we haven't been using some of these treatments for so long. And it also got frustrated for me that I see them struggling, they're navigating the transition without help, and I feel as if I couldn't help them. So this was part of the journey. And I also started some of this transitioning. And so on a personal note, I was identifying with these women and then feeling helpless. So I also did the research, and we went to a conference with the Menopause Society, did some more of just self navigation in this atmosphere. And then I was able to get certified and say, we need some local help. It's good to be able to help women navigate this journey because it's affecting their quality of life. So I still do primary care on Mondays through Thursdays. And then on Fridays, then I'm in the menopause clinic.
Very good. All right. The next question I'm gonna pose this one to to Nancy. Nancy, can you tell us more about the practice of menopause and women's sexual health?
Sure. So we focus on women's health, so from the perimenopausal transition time and support them through their postmenopausal years. So we would evaluate them, treat their symptoms, help prevent or treat osteoporosis, and anything else to help reduce the risk of, say, heart disease, dementia, or any other diseases related to aging. So we tend to work, at least for me, I work with the primary care providers because I'm not a primary care provider, and then I also work with other specialists such as gynecology and urology to just to ensure the best plan of care for them.
Okay. Marcia, just to avoid confusion, I want to throw out some terminologies to you and let you kind of speak to them. So, premature menopause, early menopause, perimenopause, menopausal transition, and postmenopause. Bunch of different menopauses. I'll give it to you and let you kind of talk about all those.
Sure, a lot of nomenclature there. Let's start by talking about what menopause is. And so, menopause is a normal, natural change in a woman's life. And that's when a woman's menstrual cycle stops permanently. So, a woman reaches menopause when she has not had a menstrual cycle for 12 consecutive months, absent any other biologic or physiological cause for that. If this happens in a woman, the average age is 51, but usually can be between 40 or 58. If a woman has this happen before they're 40, we classify that as premature menopause.
Okay.
Premature menopause can occur in women naturally or iatrogenic, which means we did something to them. So if they had surgery and had their ovaries removed, or we give them chemotherapy, then they can do premature menopause. That's the time, though, for these women where they're at high risk of developing heart disease and osteoporosis. So the women who are in premature menopause, we want to get to those women early and treat them aggressively. If a woman appears in menopause between age 40 and 45, they're in the category of early menopause.
Okay.
And if they are in menopause after 55, then they're late menopause.
Okay.
Essentially, too, any woman who has the transition, the symptoms can vary, but we also have to recognize that women can have symptoms even in their 30s while they go through the menopause transition.
I'm kind of muting as we're hearing some overhead stuff here. I don't know if you could hear that at the hospital. Um, Nancy, question for you. So, like, I'm someone watching this program. Who watching this program should pick up the phone and give you or Marcia a call and come to the menopause clinic?
So, I mean, there's a whole bunch of symptoms that we see during perimenopause. Most women will have symptoms during perimenopause instead of just waiting for menopause. So, most women will say, I'm having hot flashes during the day, or I can't sleep at night because I'm sweating at night. They may complain of vaginal dryness or irritation. Some women might think, I'm having another bladder infection, but it's truly not a bladder infection. It could just be because when they urinate, it burns from the vaginal dryness and dryness down there, and then not really a bladder infection. So if someone's coming in with multiple bladder infection and it's truly not a bladder infection, when you check it, it's probably because they're having low estrogen and vaginal dryness. If they're having libido issues, decreased desire in sex, sleep problems at night, and you're in your 40s or even in your late 30s, I would say, talk to your primary or just call us directly and see if, just to have an evaluation and see if, what we think about that.
That sounds like there'd be a decent number of people that would probably need to give you a call.
There's a lot of women in their 40s and beyond.
Yeah, yeah. All right, Marcia. Here, I'm curious. Like, so if someone calls you and
Mhm.
they're going to say, "I want to see Dr. Jones." What treatments do you have available to help them out?
So definitely call us, and we have a lot of treatment available. It's important to recognize, though, that we're going to individualize the care for each woman. We're going to take into consideration their personal history and their symptoms. We'll have a conversation, we'll discuss the treatment. We want to make sure that we understand that though there are options available, it's different for each person. We have hormonal treatment, and that could be estrogen, progesterone, testosterone. They come in various forms, patches, gels, sprays, you name it. We'll talk about those. We also have non-hormonal treatment, and those could be medicines like antidepressants or anti-seizure medicines. So the variety of medicines are there, but we have a shared decision-making process, which means we're going to offer to the woman all the options that are available for her condition and for her symptoms. Then we'll make a decision together. They may need a referral. They may need to see a sex therapist or a pelvic floor therapist, depending on what symptoms they're having. So we definitely aim to individualize the care for each woman.
You mentioned pelvic floor therapist, Marcia. Nancy, I'm going to pose this question to you. Who's that? And when would you refer someone to a pelvic floor therapist?
So pelvic floor therapists, I believe they're physical therapists, that they have a specialty in pelvic floor therapist. CGH do have several. I've met a few of them already. So one of our biggest referrals to our pelvic floor therapist is urinary incontinence. I know that our urologist, Dr. Song, do a lot of referrals to them, but what we find is maybe she's not getting the referrals for urinary incontinence. So the patients that I've seen in the last few months, when we ask about urinary incontinence, a lot of them do have it. They have vaginal deliveries, and so as a result, they have it. But they didn't think it was abnormal. They thought it's just part of aging, part of just having a baby, and they just kind of ignored it, or they wear a pad all day long. So and they don't have to. So, we ask about it. If you don't ask, they don't have that problem. So then we would refer those patients, especially with stress incontinence, we refer them to a pelvic floor therapist. But even with urge incontinence, they can benefit also from their education. The other big one is vaginismus. So someone's having involuntary muscle spasm with, like, say, vaginal penetration. I would refer them to a pelvic floor therapist also.
Okay. Um, you both have mentioned also already in our conversation about hot flashes, and another word for that is vasomotor kind of symptoms. That's pretty. I've obviously as a family practice doc, I've heard a number of women through the years talk about hot flashes. Uh, can you tell me? I'm gonna pose this one to you, Marcia. Can you tell me what they are, what causes them, and what are the treatments that are available to help women out who are having vasomotor symptoms?
So thank you for that question. Vasomotor symptoms, they're the hallmark of menopause and the transition. And at least 80% of women will experience them at one point in the transition or after in their life. People describe this as a hot heat sensation that starts in the chest, emanates to the face, and spreads sometimes through the whole body. They can have sweating, some women have cold chills. It's very anxiety provoking for a lot of women, and so they'll have more anxiety with that, even palpitations where their heart skips a beat or races a little bit. It will last about 2 to 4 minutes, excuse me, but some women can have this several times a day, or they can have it where they have it 1 week and not again. So it varies by each woman. We know that it's the change in the estrogen that causes this for a lot of women. They have the variability. So the estrogen goes low, then it goes high, and then it goes low until eventually they lose, the estrogen in their body. And that's what is causing these symptoms. We do have a lot of medications available. We have hormones and non-hormonal treatment. Last year, uh, May of last year, they came out with the fezolinetant, which is the newest medicine, and that acts in the brain where the thermoregulation center is. So it's as if the thermostat in the brain is affected by this medicine, and it actually helps women with curbs their hot flashes. So we have quite a few things, including this new modality, to help. Many women can have this hot flashes for years. I mean, the average year is 7, but some women have it for 15 to 20 years. So it's a huge burden, and it affects their quality of life. It affects their physical relationship, and even their employers can be affected because women are missing work because of this. So it's pretty common and pretty bothersome for a lot of women.
So we've talked, yeah. So thank you, Marcia. So we're talking about hot flashes. There are other symptoms too. Nancy, would you just kind of outline for the folks watching what other symptoms and complaints you tend to see in your practice?
Sure. So I mentioned some of that before. So besides the hot flashes, which is definitely a major one, Um, we talk about genital urinary syndrome of menopause. So that's the vaginal dryness, but it's just not vaginal dryness. It used to be called vulvovaginal atrophy, but in 2014, the medical literature they changed it and changed the name to genital urinary syndrome of menopause because they realized that with low estrogen, it's not just about the vulva and and the vagina. It's also involves the bladder. So it's a constellation of symptoms. Because of the low estrogen. So you can get vaginal dryness, you can get burning, irritation, you can have sexual symptoms, low lubrication, um, discomfort, pain, impaired function. You can get urinary urgency, dysuria, or even recurrent urinary tract infections. So it shows that if you treat women with estrogen, especially with vaginal estrogen, you can decrease the risk of recurrent urinary tract infection by about 50, maybe
Mm.
50, 60%.
Wow,
So,
that's impressive.
yeah, that's really important because what I see in the hospital, I see a lot of frail old nursing home patients, not even from a nursing home, but they come in with recurrent bladder infections all the time and they get really sick. That's why they're in the hospital. And I realize that hardly any of them are on vaginal estrogen, or almost none of them are on vaginal estrogens because it wasn't a thing then. But
Mm.
I just see the importance of if we can reduce the risk of, it may not reduce 100%, but even reducing by 50%, it could be life saving for some of these patients. Some of the other things that we see a lot is like muscle aches, joint pains. Dr. Vonda Wright, she's a orthopedic surgeon, and she really is into um, menopause. So she just recently coined this term, the musculoskeletal syndrome of menopause. So we see, she said she saw in her office a lot of joint pains, frozen shoulders in perimenopausal and postmenopausal women. And there's a lot of estrogen receptors there in the bones, the joints, the collagen. So if you replace some of that estrogen, you can help prevent or alleviate some of that pain. And then we always also talk about, weight training and making sure we decrease women's frailty as they age. So you don't want to be 70 and very weak, and
Mm.
every little push you fall and you break your hip.
Mm.
We see a lot of like low libido issues, hypoactive sexual desire problems. So this is very multifactorial. So maybe we'll leave that for another talk. Brain fog, we see, they say that they can't remember things. Women don't multitask as well. They might complain of palpitations, worsening anxiety, what Dr. Jones had mentioned before. She see hair loss. So will estrogen replace hair loss? Maybe, maybe not, but we see a lot of that. And of course, sleep problems with low progesterone. You can get sleep problems with hot flashes at night. If you don't treat it, women will definitely have sleep problems also.
Any other common disorders that you see in your practice for menopausal women, Marcia?
Sure. Along with what Dr. Tran just mentioned, we definitely are aging and maturing. And so they're definitely at high risk for other things like heart disease. We know we have the estrogen receptors everywhere in our body, literally from head to toe. And so when those receptors are not filled with estrogen because the level is low, then that also is going to increase a woman's risk as well. They also have risk for osteoporosis. We get a little frailty as we get older. And that's where the strength training comes in to strengthen the bone and decrease the risk. Osteoporosis is also one of the conditions where menopause hormonal therapy is FDA approved for use. They also have risk of diabetes and prediabetes and cholesterol problem. You see this in the practice where I have women who come in and they've been normal, healthy, active women. They start the transition and the cholesterol starts changing and their blood sugar starts going up. And, they're so frustrated because they're saying, I'm exercising, I'm eating healthy, I don't have anything different in my life. What's going on? But just these changes with the hormone level is increasing their risk. So for each individual woman, look at the therapy, but we also know that some of these are positively affected by estrogen and hormone replacement therapy. And then focusing on exercise, the mind diet, and just strength training helps a lot as well.
Thanks. Appreciate that. So throughout this conversation, I've heard the word estrogen, progesterone, testosterone quite a bit. And I'm wondering if some of the folks hearing those things are getting a little bit nervous, a little fearful when they hear about that because of some of the things they may have seen or read or heard over the course of the last 20 years or so. So I'd like the two of you both just to kind of handle this, but address, if you would, kind of what's going on with hormone therapy and what's changed over the course of the last couple decades, heart disease, breast cancer, some of those kind of questions that have popped up over the years. I'll leave it to the two of you to talk about that some more.
Sure, I can start that. So,
Sure.
what we found that, prior to 2002, there were a lot of studies showing benefits to menopausal hormone treatment. In 1999, they did a survey, and about 27% of women postmenopausal was on hormone treatment. And in 2020, it dropped to about 5%. So I think the current data is about 2 to 5% the last time we were at the menopause conference, but that does not include pellets because they don't have any data on that. It's just based on prescriptions that was sent out. So then what happened? Why such a significant decrease in hormone treatment? So the Women Health Initiative is a huge study launched by the government, National Health Institute. It was launched in 1997. So they enrolled about 27,000 people, women. They were aged 50 to 79, and it was meant to last 8 years. So they had two legs in the study. One was to give women estrogen and progesterone, which is the mainstay of hormone treatment. And then the other one was to give women estrogen because they didn't have a uterus, so they didn't really need the progesterone part. It was meant to last 8 years, but one leg of it, they stopped at 5 years. So the women receiving estrogen and progesterone after 5 years, so this is 2002, they said, we got to stop the study because they were showing increased risk of breast cancer, blood clots, and stroke. But when you look at the data, it was a very small number. So 2002 is when I was right in the middle of my medical residency training. And I remember the papers came out, it was all over the media, and they said, guys, we're not giving Prempro anymore. That was
Hmm.
really the main treatment. And really, that was the end of menopause training for us. So that's what happened. So when you look at the data, it showed that like of every 10,000 women on estrogen and progesterone, only about 7 women had acute heart attack. 8 women had strokes, 8 had breast cancers, and 8 have blood clots in their lungs. But they also found that 6 women have less colorectal cancer. So estrogen is known to decrease colorectal cancer, and of course, less hip fractures because it treats osteoporosis. But if you look at the overall data, it did not have any additional deaths. So even though the numbers was really small, you're talking about way less than 1%. Um, of all these problems that scaring women away from hormone treatment, there was not any additional deaths. So there was multiple problems with this study. I'm going to let Dr. Jones talk about those issues.
Sure. So I was also early in my practice when this started, and I was practicing and prescribing hormone therapy. And then in 2002, I myself stopped because of the study. And since then, I've had time to research and read more about it. We noticed at least three problems with this study that questions the outcome. And the first thing is that the women in these studies were more mature women. The average age was 63.
Okay.
And when you talk about menopause transition and treatment, we're targeting women who are a variety of age, but certainly we want to get them younger. And so the average age is 63. 70% of these women were over 70, and
Okay.
the average age was 50 to 55. So you would imagine that these women are more mature, they have more chronic conditions, and that also influenced their risk. The type of hormones used were always a question. They used progesterone, the form called medroxyprogesterone acetate, or commonly known as Depo-Provera. We use that a lot in contraceptive, like the Depo shot. And so we do know since then that micronized progesterone kind of binds differently and alters the receptors differently than the MPA. And so that's thought to be less risk with this. The time of estrogen that was used was the oral estrogen. The estrogen through the liver is the oral formulation. And so when you have to go through the liver with estrogen, you go through what's called a first pass effect. And so that increases your risk of blood clots, and that's where the stroke risk
Okay.
and clots to the lungs come up. When we treat women, we definitely preferentially go towards transdermal depending on their condition. because we know that it skips the liver. We just go directly through the skin in one form or another, and so it has less risk of clots.
Transdermal. When you say transdermal, what do you mean by that, Marcia?
That's through the skin, and so we're talking sprays, gels,
Okay.
patches, instead of a pill.
Okay.
Clarifying that. And that definitely bypasses the liver. And so we don't have to worry about the clot risk because it's safer. So I do know that looking at the studies, and even some of the authors that were involved in these studies have come out. And in 2017, they had this all cause mortality, which means they looked at all the mortality or death from heart disease and strokes and cancer. And they found that there was about a 27.1% all-cause mortality risk in the HRT group, the people who had hormones, versus 27.6 in the placebo group. So when you compare those people who had hormones versus those who did not have hormone, it was not significantly different. So now we target women younger and we try to get their conditions treated sooner and they benefit longer. And we also target women who preferentially have been in menopause within 10 years of menopause.
Okay.
Doesn't mean that they're not candidates later, but the sooner that we get them, the more they benefit, and preferably less risk associated with that.
Okay. Really interesting. How about anything else to add to that, Nancy? Oh, here's
No,
Donna had a question here. Uh, Donna was asking, how many women age 74 and above are you seeing benefit using these type of treatments?
I can start with that.
And then, and also you see the second question there is, is it covered type of stuff?
So the Menopause Society recommends that we treat women 60 years or younger or within 10 years of menopause as a first line target. So women who are older than 60, it doesn't mean that they're not a candidate. I saw a patient in the last week who was 73, and we had a conversation. This is where the actual act of individualizing medicine comes in. This has to do with their quality of life. You understand the risk and benefits. How is it affecting you? So it depends on the woman, her conditions, what symptoms she's having. Is it contraindicated? But there are women who may be candidates depending on what's going on in their life. And the important thing is the shared decision making. We're having a conversation and we're deciding together. I don't know about the coverage. That's definitely depending on the plan that person has, I think.
Yeah. I would think that you all had mentioned the vaginal dryness and atrophy. Would that be something that even if you're a little bit older, that would be something that would be treatable, even if you're not going to go the patches and all that kind of route?
absolutely. Yes. Every woman should have a tube of vaginal estrogen
Every
in their
woman, that's a
house.
pretty strong statement. Okay.
And yeah, I've spoken to our oncologist, Dr. Alakan and Dr. Al Sayed, even breast cancer patients, because they are stripping them of estrogen a lot of times with their treatments, right? So they're going to have a lot of problems. And if these women are young, they're in their 40s and they're having sex issues, marital issues because of that, I think if we can fix it, why not? And it's not contraindicated.
Yeah, good. Donna, thanks for the question. Oh, and in terms of, and this is Christine, your thoughts about HRT on a woman with breast cancer history. Dr. Tran, you already alluded to that, but I'll let you kind of just one more time speak about that.
Sure. So breast cancer, I can't say, I always think about like red lights, yellow lights as to who can or cannot receive um, hormone treatment. So there's this great book, Menopause Matters. I'm not sure if some of you guys might be familiar with that. It's written by an oncologist, and he talks about how it's safe to give estrogen with breast cancer patients. You just have to individualize it. You have to see which treatment is the best option for you. And because we believe that estrogen doesn't cause breast cancer, it doesn't cause the mutation to cause breast cancer. It may help grow a breast cancer just like any other nutrients in your body, but it doesn't cause it. So really it's a decision between you, myself, Dr. Jones, and maybe your oncologist. But in the end, it's really the patient, right? So if the patient says, I'm okay with the risk, my life is miserable, let's go ahead and try it, then we might be open to it. So
Anything you'd add to that, Marcia?
I definitely agree. And I think that's a great book, Estrogen Matters. And I think one thing I always think about is millions of women are pregnant every day in the world, in the United States, and that's when our estrogen level is the highest. And how many women do we hear about that actually get breast cancer when they're pregnant? It's not a lot. And so that's where it's important to realize that all this in context, estrogen may contribute or, cause a cancer to grow differently, but we don't think it causes it. And to the point about vaginal estrogen, I'm of the opinion that, most, if not all, women in their late 30s should start having vaginal estrogen, in their 40s for sure, because most of the time I see women who are having symptoms early 40s, and it's usually just a little urgency or maybe some pressure with urination, and they've had multiple workups for bladder infections, and that's negative. They don't have it, no infection. And that's usually the first symptoms that they're having that indicates that they're having some problems. So I think it's very safe, and every woman can have a tube and use it.
I'm hearing this every woman needs a tube thing, so I know we're going to stick with that one. And then Christine's asking, HR is the best thing I've done during this time. Definitely a game changer. Get in touch with doctors ASAP. So, and then another one, so glad that we finally have help in the area. Thank you, doctors. That's from Melissa. And then don't hesitate, make an appointment. You won't be sorry. Best thing I've done. Well, thanks, Penny. Very nice. Boy, these comments keep coming. All right. Yeah, I think what you're saying is resonating, ladies. With some folks we talked about before we had our interview that we thought folks would be very interested in this. And on my HRT, they took me off because of the reasons you mentioned. 68 pre-diabetic osteopenia, weight gain plus 40. Would I be a candidate again for HRT?
And to that, I would say it's certainly a conversation to be had, not something to be addressed on this forum, because we'd have to have a conversation about your conditions and your symptoms and go from there. But call us and we'll talk.
And we'll give you vaginal estrogen at the minimum.
One final question. Menopause event. I'll let both of you kind of hit on this. A menopause event. Can you tell me more about that?
Sure. Here it is. So we're having a ladies' night on April 10th at a location to be determined. So just kind of look out for that. I guess our plan is Dr. Jones and I will be there. We'll probably have maybe a couple of other specialists there. We'll have talks, food, just kind of like mingling and just to learn more about menopause and sexual health. Okay. So we will invite the whole community to come if possible.
All right. Awesome.
Male or female.
Sure. And bring your questions. We can talk and learn more about menopause, and it's planning to be a good event.
Yeah. Well, Dr. Jones, Dr. Tran, thank you for your time. I appreciate all you're doing in this clinic. I think it's a wonderful thing. I think it's going to be really helpful for women in this area who are going through some piece of that process. So glad you're doing what you're doing. And you can see down below on the screen there what number you would call and where you'd be going if you were going to be seeing either Dr. Jones or Dr. Tran at the Menopause Clinic. So Dr. Jones, Dr. Tran, once again, thank you so much for being on Facebook Live. And maybe sometime in a year or so, we'll have you back and you can report in on how things are going and tell us some success stories.
Sure.
Yeah, that'd be great. My pleasure.
Okay. Thanks, ladies.
Thank you.
Thank you.
Okay. Very good. Thanks. Before I let you go, I have a few other slides. I'd just like to highlight some people we want to highlight here at the hospital. Jill Bryan. Jill works in our Digestive Health Center, one of our folks who helps out with patients who are having colonoscopies and upper endoscopies. And she was our December Employee of the Month. So once again, Jill, congratulations on that. And Amy Anderson is a billing analyst in patient accounts. And congratulations to Amy. She's our January Employee of the Month. I was there for that presentation for Amy, and she was very surprised. That was a fun moment to watch Amy's face when she got that award. Blood drive, February 6th. On February 6th, at Thursday, which is the North Locus is up north by I think it's Benny's restaurant, kind of up there by the old Candlelight. So yeah, blood drive, please sign up, please walk in. Definitely could always use blood if you're healthy and able to give. And finally, next month, it's Heart Month. And so why not have cardiology folks on? So we're going to have our new cardiologist, Dr. Rashid, and our new cardiology nurse practitioner, Mary Madison. They are both over in our Morrison office. So we're excited to have them on next month, and we'll be asking them some heart-related questions. So please plan to join us for that. Okay, well, hey, I've taken enough of everyone's time, but I think this has been a really good topic, and I thank everyone for watching. And as I said at the beginning of this broadcast, if you've found it helpful, pass it on to some other folks who you think might benefit as well. So until next time, thank you for watching. This is Bill Bird, Chief Medical Officer at CGH Medical Center.